Hello, it's Jeremy Faust, editor-in-chief of MedPage today, and thank you so much for joining us. I am going to be joined by Dr. Craig Spencer. Craig, it's great to have you. Thanks for joining us. What's going on right now in New York?
Well, as a lot of people have probably heard, we have had another huge surge of cases here. And although, going to work now is not at all the same as it was in March 2020, where walking into the emergency room felt like the apocalypse, it's still quite daunting because we have a huge number of cases. We've seen a big increase in hospitalizations, and we've seen the impact that even a relatively milder Omicron, not mild, relatively milder variant can have on increasing the number of people that are coming into the emergency department and needing to be hospitalized.
You've written in The Atlantic and in the New York Times recently about workforce issues. What's the mood there? I think here in Boston, we've always kind of dodged the bullet. It's been rough, but we've never had the real catastrophic sort of moments that I fear that you have. So I don't know what the sort of, how's morale, if you will. So how is morale?
No, it's tough, right? Like in March and in April of 2020, we had so many of my colleagues that got sick. I had colleagues of mine that came out of retirement to fight COVID who died. I almost had to intubate one of my residents because they were, so hypoxic and looked so bad. Morale was pretty bad in May of 2020. Since then, we've had these undulating waves of COVID that have come and gone. In between, we've had a lot of other systems issues where in New York City, we've had ED overcrowding for a long time. We've had boarding that has been an issue from before the pandemic. And each of these were exacerbated by COVID. And we haven't figured out the answers in the ensuing 2 years because it seems like every time we want to work on this, we have, another one of these waves of COVID patients that are coming in. And the Omicron surge recently has only complicated that because it's building on so many other previous issues that we had. For staff morale, it's been tough. Of course, we're going to come to work as much as we can, but there are only so many shifts that we can step into if we're already working a bunch. And we can't work shifts if we have COVID. And that has been the biggest issue for a lot of staff in my hospital and in every single healthcare structure, nursing home, whatever it is here in the city. We have so many of our staff, despite having been vaccinated, who have breakthrough infections, who are sidelined for 5 days or more. And thankfully, I'm glad they're vaccinated because I'm not worried about them, coming in hypoxic, short of breath, needing to be intubated, or even worse, dying of COVID like I was at the beginning of the pandemic. But still, it sidelines them, puts more pressure on the rest of the team, and makes it harder for us to provide the quality of care to the patients that we expect and we want to be providing.
We saw in our dashboard, which follows hospital capacity, we're looking at staffed beds, which is the important number, not beds, staffed beds. You need people. And I know you've talked about this. And we'll see a place like New York overnight drop their staffed bed capacity, what they think their true sort of what we could handle, drop by 5,000 beds in one night. We've seen that. And that's obviously because the sidelined workforce. And at the same time, you have the CDC putting out these guidelines saying, depending on the situation, you could have 10 days at home or 7 days in a negative test if you're a healthcare worker. But then there are these other sort of caveats. There's the contingency caveat or the crisis caveat, depending on what level of mayhem you are seeing, in which case people can come back to work sooner than even that 7-10 days guideline. Did things get to the point where people were coming back to work early in New York that you saw, or were they pretty much able to isolate for a longer period?
Well, we started getting hit with Omicron kind of before the CDC or as the CDC was changing its guidelines. And as far as I know, I don't know of any institutions that have put in place those kind of, crisis standards of care, meaning that providers can come back, especially if asymptomatic, even, during the first 5 days, even if they test positive. I haven't heard of anywhere that has been doing that. Although at the same time, I've heard of so many places where staffing shortages have been so severe that perhaps that would have been justified. I knew of emergency departments out on Long Island that had, less than 10 nurses to staff the whole emergency department. I know of other places where, they have 2 nurses taking care of 30, 40, 50 patients. And so, we've all gone into work here. Everyone working in New York City has covered extra shifts, has seen severe staffing shortages amongst physicians or respiratory techs or amongst nurses. This has been reflected as well, even if the number of absolute beds kind of drops, what isn't part of that, equation is the fact that, like, even if we have a smaller number of beds, we have a much smaller number of people to take care of them if they're out or for whatever reason. And so your ratios are going to be different. If you have 80 beds, beforehand, and you have 5 or 6 nurses to take care of those patients in those 80 beds, it's very, very different, a different experience for the nurse and for the patients if you've got 2 nurses to take care of those 80 beds. And that we've been seeing a lot more of the latter in recent weeks. Thankfully, it appears that some of those staffing shortages are starting to resolve a bit, with so many people having been infected at the end of December, early January, and with the change in some of the recent CDC guidance letting people come back a bit earlier, which seems to have been adopted by most hospitals, around 5 days, especially if not febrile for the previous 72 hours. But again, like we're on the descent here, it looks like, in New York City, but we are definitely not off the cliff, and we are not in the clear. There's still going to be other providers that will be infected. We'll still have staffing shortages, but I'm hoping that we have skirted the worst.
Let me ask you to put on your advocacy hat for a second. We've been talking a lot about hospital capacity. When I talk about the idea of circuit breakers, that is, actions that are supposed to keep it so the hospitals don't overflow with patients, there's really 2 categories I think about: hospital-based action and public action. Hospital actions are actually turning out to be the ones that are palatable: canceling elective procedures, changing your staffing ratios if you have to. I've found in my work that it's really impossible, it's very difficult to get public officials to do anything to fix this right now that can help. And there are a lot of things they could do. So my question to you would be, if you could get the ear, and I know you have it, but if you could really get the ear of the mayor, of the governor, of the White House task force, of the CDC, what's the one thing that the public officials could ask the public to do, or public officials could do right now that would have an impact on the next month to make this better?
That's a really good question. It would be interesting to kind of reflect on this every month for the past, 23, 24 months, and see if and how any of that has changed. Look, and I think that there are micro things and more macro things. From a micro level, I've gotten a lot of pushback from people who say that, what is a mask going to do right now anyways, right? Omicron is so incredibly transmissible, like why even bother? Or why get vaccine? Why get a booster if it's just so incredible? Even people that are vaccinated or boosted are getting infected. And I think that we are confusing what can be beneficial, what is necessary, what we want to be perfect. We know that masks work. Yes, people should be wearing masks, but they shouldn't be wearing, 2-ply surgical masks. They shouldn't be wearing cloths or bandanas or whatever it may be. We are 2 years into this, and I'm disappointed that instead of putting in place travel bans at the end of November, the administration didn't say, well, this sounds really transmissible, it's concerned enough, and didn't send out KN95s, or didn't do what they could to get better high quality masks into the hands of every person living in this country. I think it's, a reiteration of the things that matter for a shorter period of time. If these waves are indeed shorter than a Delta or previous waves, say, look, we need to give people an off ramp for when we're going to, potentially say that we're going to keep things open, or we're going to, get rid of these mask mandates, give these off ramps so people have something to look forward to know that this is not a 2 or a 5 or a 10-year sentence. And I think, again, the other really important thing that I would say to anyone in this administration, as I have and will continue to, is that Omicron is not the last. In a sense, we got lucky that Omicron was not more severe, not more lethal than previous variants. It is hard to deny that there will be more variants, and it's quite possible that the next one can be more dangerous and more deadly. We know that the best way to protect against more variants emerging is to protect people from getting infected, to prevent them from spreading. And a great way to do that is to increase vaccine supply globally, not just in the US, not think about this as building walls or building a moat around this country, but engaging better on the global sphere to get more people vaccinated. The administration has done a better job of that in recent months, but we got a slow start and we have a long way to go. I think another thing that would be helpful at the larger hospital or policy level is that, look, in the US, medicine is a business, right? It is no coincidence that in New York City, in the 13, 14 years that I've been here since I started my residency, the majority of hospitals have been bought up by large conglomerate healthcare systems. Medicine is a business, and a business focuses on the bottom line, even if we still want to take care of our patients and do all those things. So there has been a focus on, operations, often at the expense, quite honestly, of what is best for providers. Having the resources that we might need in terms of the number of nurses, or having the things available in our emergency departments, the right number of staff, doctors to increase ratios, et cetera. What we ended up coming into the pandemic with was already overburdened healthcare systems, where people were on top of each other, where we didn't have enough nurses for all of the patients, where doctors were working a bunch of shifts, so we're taking on a lot more patients than we probably needed to, signing on a lot more patients. We needed more resources before the pandemic came. Now we've had a lot of people who have left because of the pandemic. We're short-staffed. We need to go back and recognize that, continuously focusing on and relying on healthcare providers that are overworked and overstretched in hospital beds that may not be as resilient as we want them to be, at least on paper. We need to make the policy choices to turn healthcare into healthcare first and a business second, if at all.
Well, thank you for being on the front line, for being a resource to me and a friend. We've been through a lot together, even though we've never met in person. And I continue to marvel at all that you are achieving down there, and also have a little bit of sideline guilt, like, can I jump down to New York and scrub in, get my PPE on. Thank you so much, Dr. Craig Spencer, for joining us.
Thanks for having me.